Hi, my name is Dr. Ashley DeLeon. I am a board-certified general surgeon and a fellowship-trained transgender surgeon who practices at the Crane Center for Transgender Surgery in Austin, Texas. Today we're going to be talking about chest masculinizing surgery and specifically the keyhole operation, which is an important step in the treatment for some trans men or non-binary gender fluid individuals who are seeking gender affirmation surgery. Specifically, we're going to, as I said, we're going to discuss the keyhole operation, subcutaneous, nipple sparing, and skin sparing mastectomy that we commonly refer to as the keyhole. So the first step is to schedule a consultation with your surgeon. We will send you some intake forms, either in paper or electronic or digital forms that we will ask you to fill out prior to your consultation, which will kind of ascertain your medical history, and then your surgeon will review those forms and then have a discussion with you during your consultation regarding your medical history so that we can ensure your safety and good surgical outcomes. The first piece of this is your past medical history. Your past medical history is any psychiatric or medical problem you've been diagnosed with or received treatment for. And that is specifically make sure your heart and lungs are healthy, your kidneys and liver are healthy to undergo surgery. There's also some specific things that we may hone in on and want some more information on that particularly relate to surgery. For example, obesity. That's very important. Obesity is defined as a BMI over 30. BMI stands for Body Mass Index, which is a number that takes into account both your height and your weight. It's not a perfect science, but it's usually fairly accurate for most, and it's how we classify obesity here in the United States. And so if you have a BMI over 30, you're technically classified as obese. Anything over 35, when you get into class 2 obesity, you really need to make sure you let your surgeon know, especially if you're doing a phone consultation instead of an in-person office consultation, so that there can be a discussion in place to make sure that we ensure your safety for surgery. Specifically, patients with obesity are going to have increased risks of wound healing complications. They have increased risks of postoperative infections, anesthetic complications, general surgical complications, and then also they have increased risk of blood clots after surgery and also postoperative pneumonia. So that's why it's important to have that discussion with your surgeon prior to surgery. If you are hoping for a keyhole operation and have obesity, then this is probably not the operation for you, and we should be talking about double incision top surgery. So again, if this is an issue, just please make sure you bring it up to your surgeon at the time of consultation so you all can figure out the best approach for you. In addition to that, bleeding disorders are very important for a surgeon to know about for obvious reasons, as well as the converse of that, which are blood clotting disorders. Those are also important to know about prior to going to surgery, as well as collagen vascular disorders, which can have problems with both wound healing and bleeding, depending on the type of collagen vascular disorder that you may have. And so that's an important thing to bring up to your surgeon as well. Diabetes is an important one. Again, similar to obesity, it can impair your wound healing, increase postoperative infections, complications from anesthesia, those kinds of things. But then in addition, it's important to know if you're diabetic so that we can properly manage your blood sugars around the time of surgery. HIV is another one. For HIV patients, we may require that you have a letter from your infectious disease specialist or primary care physician or whoever it is that's managing your HIV and prescribing your medications. We will require that you have a CD4 count and a viral load that's fairly recent so that we can make sure you are medically optimized to undergo surgery and that we are doing something that is safe. In addition, if you have any personal history of breast cancer or other breast-related problems or biopsies, that's very important for us to know about as well prior to surgery, so please be sure to let your surgeon know. The next thing we're going to discuss is your past surgical history. This is any surgery or procedure you've had in the past, kind of from head to toe, which is helpful for us from the standpoint of making sure that you don't have any problems tolerating general anesthesia, how you respond to anesthesia, maybe how you scar, since scarring tends to be very genetic. And then also, when you're talking about past surgical history, specifically for the keyhole operation, we really need to know too if you've had any other chest surgeries. So some of our patients have already had breast reduction surgeries when they were younger, so forth and so on, biopsies, things like that. Those are things we need to know about. It affects the scarring, the blood supply, everything else. It's not that your keyhole surgery is not doable after that, but it's something that we need to know about beforehand, prior, so that we can make sure we plan appropriately. Medications that you're taking are important to discuss, specifically if you're taking any blood thinners. These are medications that either affect your platelets or affect your coagulation ability, your ability for your blood to clot. This could be anything from fish oil, aspirin, Plavix. Then you talk about Pradaxa, Eliquis, Xarelto, Coumadin. All these things are going to thin your blood and can cause problems during surgery. And so these medications need to be managed appropriately around the time of surgery. So be sure to let your surgeon know if you're taking any of those. Steroids is another class of medications that's important to know about. Sometimes patients are on chronic steroids like prednisone and things like that for autoimmune disorders and various other things. These impair wound healing, first and foremost. And then in addition, if you're on chronic steroids, then your steroids need to be dosed differently around the time of surgery. It's called stress dosing for steroids. That's also important so that you don't have any problems such as cardiovascular collapse when we induce anesthesia. Other than that, if you are a patient that is taking testosterone prior to surgery, I do get questions a lot about that. And just so you know, you are allowed to continue your testosterone throughout the surgical period. I have no restrictions on that for keyhole top surgery. Allergies to medications are important to discuss, especially if you have any allergies to antibiotics, which can be fairly common since we do use those in the preoperative setting to prevent postoperative infections. So let your surgeon know if you have any drug or medication allergies, in addition to an allergy or sensitivity to latex, as a lot of surgical supplies and equipment include latex in them and can cause problems. So we need to be sure that we are using the proper gloves and equipment and things like that so that we do not give you an allergic reaction. Social history. The most important thing about social history is your nicotine use. In our eyes, nicotine is a very potent vasoconstrictor, which means it clamps your blood vessels down. If your blood vessels are clamped down, then you cannot get the appropriate blood supply to the tissues. After surgery, when you're trying to heal a surgical site or a surgical wound, you need proper blood supply because the blood is what's bringing your oxygen, your nutrients, as well as all your cytokines and inflammatory cells to help you heal that surgical site. So if you're taking any nicotine products during that time, it can significantly and very severely impair your wound healing and cause some pretty significant problems. So we ask that you abstain from all nicotine-containing products for at least a month before and a month after the time of your surgery. And this does not just mean cigarettes. This also means your use of vape pens that contain nicotine, lozenges, Nicorette gum, patches, you name it. If it has nicotine in it, do not use it around the time of surgery. And we may ask that you take a specific blood test to confirm or urine test to confirm that you have been abstaining from nicotine to make sure that you have a good and safe surgical experience. For family history, which is kind of the last component of your medical history we'll discuss. Most importantly, problems with anesthesia that may run in the family is good to know about. Bleeding disorders that run in the family, also very good to know about, again, for obvious reasons. And then also specifically for keyhole top surgery, if you have a very significant family history of breast cancer, that's also important to know about beforehand so that you can discuss with your surgeon any screening or other modalities or things that need to be done in advance prior to surgery to ensure your safety. After we discuss your medical history, we go through the surgical information, ask questions, talk either on the phone or in the office, and then once the consultation is complete, the next step is to get your letter on file to us so that we can submit for insurance authorization. We follow WPATH guidelines, and for top surgery in general, we need a diagnosis of gender dysphoria, that you have been living as a man for over a year. If you are a non-binary gender fluid individual, then you need to be living as a non-binary gender fluid individual for over a year. And then we need a letter from your a mental health provider. The letter from the mental health provider needs to be in support of the surgery and in support of the transition. And then we will submit, once we have your letters on file, we will actually reach out to your insurance company if you're planning to use your insurance. And we're proud to say about 90% of our patients are covered by insurance. We will submit for insurance authorization and start that entire process once we have your letters on file. We will also at that time give you a big packet of patient information in regards to the surgery specifically that will have a lot of pre and post-op care instructions. It will also have the date and location of your surgery once we find a surgery date for you, and it will also give you the dates up front of your pre-op and post-op visit, which is helpful for our patients that are traveling from out of town, out of state, or out of country, of course, so that they can plan accordingly. We will likely require that you have some labs drawn prior to surgery, and so we will send you in the orders or the lab slip for that. We typically will get a complete blood count, which looks at your hemoglobin, your platelets, your white blood cells. We'll get a metabolic panel that looks at your electrolytes, your liver function, your kidney function. And then coagulation studies, which look at how your blood clots, how fast does it clot, are your platelets functioning, and things of that nature prior to going to the operating room. We may actually request that you do some additional lab studies depending on what your overall health status is and medical problems are. For example, if you had HIV again, as I mentioned previously, we would need like a CD4 count and a viral load, and maybe a letter from the physicians who's managing your HIV. It's just an example. We may request that you obtain surgical clearance if you have a significant cardiovascular history. We may, request that a cardiologist, do a workup and let us know some perioperative recommendations of how we manage your heart around the time of surgery to ensure that it's safe for you. We may require you to get an EKG to look at your heart, a chest X-ray to look at your lungs. It all is going to be very individualized and vary depending on you and your medical history and your health status. And so that will all be done prior to surgery. The next step would be the pre-operative visit. For the pre-operative visit, if you did, that will give us a chance to meet in person if we did a phone consultation, or at least see you again if we did an in-person office consultation initially. But for the pre-op visit, you will come in person to the office, usually a couple days or a day at least before your surgery date. We'll meet in person. This will give us a chance to update your medical history, make sure there has been no changes since we last spoke. Do a physical exam. We'll fill out all your hospital paperwork. We will sign consent forms. I will give you prescriptions so that you have those prescriptions to go home with, and you can get them filled and ready for you for after surgery, so you're not scrambling around to go get prescriptions filled when you are already not feeling 100% anyways. And it also gives you another opportunity to ask further questions prior to going to the operating room. Once the day of surgery arrives, we typically ask that you get to the hospital or surgery center about 2 hours prior to your surgery time. This is so they can get IV started, get you in your hospital gown. You'll meet with anesthesia, you'll meet with the OR team, and you'll see me or your surgeon before to ask any last minute questions, maybe make a few marks prior to rolling back to the operating room. And then at that point, anesthesia will give you a little cocktail, make you kind of loopy, no anxiety, really relaxed, so that you're not stressed. And then we will take you back to the operating room from there and get you to sleep. This operation is under general anesthesia, so this means you're going to be completely asleep. And it is an outpatient operation, which means you go home the same day. You are not going to stay overnight in the hospital. You will get to go home that same day. And the whole operation for specifically the subcutaneous nipple and skin sparing mastectomies or keyhole top surgery takes anywhere from 2 to 4 hours, depending on how things are going. While we are In the operating room, remember for the keyhole operation, we are not removing any excess skin, and we are not doing nipple grafts. So your nipple and areola are going to stay, they're not going to change significantly in their shape, size, or location. No excess skin is going to be removed. So how we do this operation, we make a peri-areolar incision, which means you're going to have a small, couple centimeter incision right on the underside of your areola, right where it meets the skin border, okay, so that it's hidden. It's a tiny little incision. We're going to make that, and then we're going to be using lighted retractors to go in there and excise out and remove all the mammary tissue through that little incision, okay? Because this is a little bit different than double incision top surgery, where we have everything wide open and can use different techniques to mitigate fluid accumulation, to close down the space so that we don't have to use drains. In the keyhole operation, this is not the case because we're working through a tiny incision. And that's the whole point of the keyhole, is so that you have really minimal scarring. But because of that, this operation does require the use of drains still. So after we've removed all the breast tissue on both sides, we're going to place a drain on each side that will come out somewhere kind of under your surgical site, one on each side, okay? And then we're going to close your incision. Your incision will be closed with sutures that are all under the skin and dissolve over time, and then covered with small pieces of white tape called steri strips to utilize as the dressing. After that, and after the drains are in place, we're going to put a bunch of fluffy stuff on your chest, and then we're going to put a surgical binder around your chest, and then you will go to the recovery room. So that's how you're going to wake up in the recovery room, with a surgical binder on and 2 drains in place after the keyhole top surgery. The recovery room, you're typically in the recovery room for about an hour, maybe a little longer, and that's mostly to make sure your pain's controlled with oral pain medications, that you're able to tolerate liquids without any nausea or vomiting or feeling sick. And then after that point, they will allow you to see your family or friends or whoever it is that came with you, and they will allow you to get dressed, go through discharge instructions with you and, your people. And then they will be able to, at that point, take you back to your home, your Airbnb, or your hotel, depending on where you're located. From that point forward, you're really kind of on autopilot, because you have this surgical binder on, right? And I don't want you to get your chest wet at all. And so you're going to be taking pain medications. I give opiate or narcotic pain medications to help with pain control. I also give muscle relaxers so that your pec muscle, if it's spasming and causing pain, that helps to augment your pain control with muscle relaxers. And then in addition to that, 48 hours after surgery, so 2 days after surgery, when you're out of the bleeding window, I will also allow you to take over-the-counter anti-inflammatories like ibuprofen or naproxen. Brand names would be like Motrin, Advil, Aleve, those kinds of things. You're able to also add those into the mix to help augment your pain control and decrease inflammation 48 hours after surgery. I'll also give you a little nausea medication just in case the general anesthesia makes you nauseous, or if you get nauseous with your pain pills, so that you have that available to you as well. As far as food is concerned, you're able to eat anything you want after surgery. However, since you're going to be under a general anesthesia for 2 to 4 hours, which can sometimes cause nausea or vomiting, I do recommend that you start out slow with like sick foods to kind of test the waters. Soups, crackers, Jell-O, popsicles, things like that. Kind of test things out, see how you feel. If you don't have any nausea or vomiting after that, and you're feeling fine and are craving or hungry for more normal meal, then that's fine as well. I just want to make sure you're not going to make yourself sick, kind of right out of the gate. So always test the waters and see how you do. As far as a bowel regimen, it's very important that you're on a bowel regimen after surgery. Even though I'm not operating on your belly, every surgery makes your gut, your GI tract, your intestines slow down. It's the combination of general anesthesia, which slows your gut down, The stress of surgery on your body slows your gut down, and then on top of it, the pain pills are constipating. So all of these things are working against you. Keep in mind, even though, again, I'm not operating on your intestines or in your belly, but regardless, you're probably not going to have a bowel movement for several days after surgery, maybe even up to a week sometimes. That's all normal. But the point is that you need to be on a bowel regimen with stool softeners and whatnot to ensure that you get back to normal as soon as possible and that it's not an uncomfortable experience. And so I usually recommend over-the-counter stool softeners such as like Colace and Miralax. Those are my favorites, but whatever works for you is fine. And make sure you're doing a good bowel regimen, especially just while you're taking your narcotic pain medications that are going to constipate you. And then also make sure you're drinking plenty of water because it helps pull water. Those medications work by pulling water into the colon. If you don't have water to pull in, they're not going to work. So drink plenty of water, take your stool softeners or bowel regimen, and then also do some walking. Walking's important because it's going to help wake your bowels back up and help with that. And then in addition, walking is going to just prevent you from being stiff and in pain. And it's also going to help keep your lungs and lung bases nice and open so that you don't get a postoperative pneumonia and help prevent blood clots as well. So I definitely want you walking after surgery. You can also climb stairs. I get that question a lot. That's no problem. The only activity restrictions I have is I don't want you lifting anything over 10 pounds and I don't want you reaching overhead. You do not have to be like a raptor with your elbows attached to your hips and, hunched over, sleeping in a recliner and come in like that. That tends to be the most common thing I see because patients feel like their chest is tight from removing all that tissue. And so they kind of want to hunch over. You do not have to sit or lay like that. You are certainly allowed to lay flat on your bed, on your back. That's no problem. You can stand up straight as you're walking around. You can do stairs. You can bring your arms up to here where you make a T. Okay, no problem with that either. The only thing I don't want you doing is lifting over 10 pounds or reaching up over your head like this. And that's because if you reach over your head like this, you're going to put too much stress on a very fresh incision. And what that does is it makes you scar wider. And the whole thing we're trying to avoid is, wide scars, especially with a keyhole operation where we're, trying to hide the scar to where the surgery almost looks scarless. So that's why we have those activity restrictions in place. Again, you're going to have the surgical binder in place for that first, 4 to 7 days after surgery. So unfortunately, you're not allowed to shower because you cannot get your chest wet in any way. So for those first 5 to 7 days after surgery, before you come see me for your post-op visit, you can do sponge baths, you can wash your hair in the sink, but ultimately, again, I want you on autopilot. Leave your binder alone, leave your chest dry, don't touch it, don't look at it, leave it alone, and take pain meds if you need them, catch up on shows, whatever you need to do, but do not get your chest wet. Remember, you will also have drains in place after the keyhole operation, and so the recovery room nurses will teach you and your friends or family how to care for those, but you are going to strip, empty, and record the output of each drain until you come back and see me in the office. I want you to write that down. How many milliliters is each drain putting out in one day? So your right drain puts out this much in one day, your left drain puts out this much in one day. That's what I need by day to day when you come back for that post-op appointment. So be sure that you are caring for those as well. And it's very important that you learn how to strip the drain as well so that you don't get it clotted off. And the recovery room nurses will give you that type of drain teaching and education at the time. As far as hormones are concerned, again, big thing, you can continue your testosterone. It's a question I get a lot, no problem. If you are taking testosterone, you are welcome to continue it. Your post-op visit is typically, again, going to be somewhere between 4 to 7 days after surgery, around a week after surgery. At that visit, we're going to remove your surgical binder and take a look at the surgical site. We're going to throw away all the fluffy stuff and take a look. Remember, the binder, we're going to take the binder off, and we may, though, ask that you take it home, wash it, and dry it, and wear it again for another week when you're not showering. And that is because with the keyhole operation, if we remove the drains at your post-op visit, then take the compression from the binder off, sometimes you can have fluid accumulation underneath your surgical site. And so to prevent that or mitigate that, sometimes we may ask that you keep your binder and just wear it, in between, showers and stuff, after you wash it, for one more week after surgery. So you may be asked to wear a binder for 2 weeks instead of 1 week with the keyhole operation, and that is to prevent fluid accumulation. At that post-op visit, also, most of the time, we're able to remove both of the drains. It will also depend somewhat on the output that you're going to bring to me with your log of how many milliliters each drain is putting out per day. But 90 to 95% of the time, we're able to get both of the drains out at that post-op visit, which is nice because then that relieves some of the discomfort from the drain sitting on the chest wall. For the incisions themselves, remember there's no sutures to remove. All the sutures are under the skin and dissolve over time, and they're dressed with little white pieces of tape called Steri strips. Those stay on for about 2 to 3 weeks and then start to come off on their own. So there's really no, important, at that visit, anything we do with the incision itself. However, we do need to take a look at it and make sure that things look like they're healing well, no signs of infection, hematoma, so forth and so on. After that visit, after the post-op visit, you get to start showering. Yay. And just keep in mind, I do not want you to submerge your chest in standing water of any kind for a good 2 to 4 weeks, depending on how you're healing, okay? And the reason is because until that top layer of skin has completely sealed shut, if you are submerging in standing water, you are at risk for getting a freshwater infection, which can be very, very severe and cause significant problems. So running water from the shower only, let the warm soapy water run over everything, pat it dry with a towel, keep everything clean, dry, leave it alone. But no bathtubs, pools, hot tubs, lakes, rivers, anything like that for 2 to 4 weeks, depending on how things are healing. After the post-op visit, again, which is usually around a week after surgery, after that post-op visit, you are allowed to return home if you came from out of town or out of the state or out of the country. Most of my patients, from a recovery standpoint, most of my patients after keyhole top surgery return to work after about 2 weeks. Some less, some more, but on average, I would say about most take about 2 weeks off work. Just remember from an activity standpoint, non-strenuous, no lifting greater than 10 pounds and no reaching overhead, again, for about 2 to 4 weeks, depending on how you are healing. Keep in mind, too, the final cosmetic result or aesthetic result that you can see, you're not going to appreciate until about 9 months to a year out from surgery because it takes that long for the collagen to turn over in the wound bed, for scar contracture and scar maturation to occur. And so your final result, and also with the contour and stuff of the chest wall, lumpy, bumpy things, as well as sensation, because it takes 9 months to a year for peripheral nerves to regenerate since they only grow about 1 millimeter a day. So for sensation and like the final aesthetic, that's all about 9 months to a year out from your surgery date. So just keep that in mind and try to be patient. Overall, though, this is a really well-tolerated surgery. Most patients do great. To go through like the advantages and disadvantages of doing the keyhole operation versus doing a double incision, so that you're aware. The advantages over double incision of doing a keyhole, as you probably already know, is scarring, right? Because a double incision, you're going to have a large inframammary scar under the bottom border of your pec major muscle. With a keyhole, it's a very small scar right along the periareolar border, meaning where the bottom portion of your areola meets your skin. So it's very hidden. There's no such thing as a scarless surgery, but honestly, for top surgery, keyhole comes pretty close just because it's so well hidden. And so that is one of the advantages. The other advantage is that you don't have to worry about nipple grafts. With double incision top surgery, we are taking the nipples completely off the body, reshaping them, resizing them, thinning them, setting them aside, and then putting them on in a completely new spot on the body. So because of that, patients who get double incision top surgery are caring for nipple grafts and also have to worry about losing the nipple graft. With keyhole surgery, that is the other main advantage of this operation, is that you don't have to worry about nipple grafts because we are leaving the nipples alone for all intents and purposes. Disadvantages over double incision. The disadvantages of keyhole are that it requires drains. We are unable to do our internal progression or tension sutures or quilting sutures that we do to close the space down in double incision, which is what allows us to not use drains in double incision top surgery. But unfortunately for keyhole, since we're working through such a tiny incision with a lighted retractor, that's not a possibility. And so you will still have a drain on each side after the keyhole operation. Another disadvantage, we do require a little bit longer use of the binder sometimes with the keyhole, again, for the same reason when we talk about the drains. We just need that compression for a couple weeks to minimize fluid accumulation under the skin or under the flap. The other disadvantage of the keyhole, and in my mind, honestly, the biggest disadvantage of the keyhole operation in general, not necessarily for you, but just in general, is that we're not removing any excess skin during the operation. So you have to have a very small chest to start with, and you have to have almost no ptosis. Ptosis means drooping or more pendulous breast. This is, none of this is addressed with the keyhole operation, right? So you have to be a very specific candidate for keyhole in order to have a good result. The other piece of that is that we are not changing the nipple areolar complex significantly in any way, shape, size, or location on your chest. So if you have a significant asymmetry, maybe one nipple's up here and one nipple's down here, not uncommon. Most people are not. In fact, nobody's actually fully symmetric, but some are more prominent asymmetries than others. And if you have, a fairly obvious asymmetry, that is not going to be easily corrected with a keyhole. And then in that case, I would more recommend a double incision. The size also comes into play, right? We can possibly reduce it a little, but there's really just no significant nipple or areolar work during a keyhole operation because of the nature of the technique that's utilized. And so because of that, there's just, it's much more difficult to find a good candidate to do a keyhole versus double incision, which can work for anybody. So for a keyhole operation, I would say the disadvantage, in my opinion, that's the most important, is that it needs to be selected in the right or the appropriate patient. Otherwise, I have seen patients come from other places that have had a keyhole done in the wrong patient, and the results can be absolutely devastating. And we've tried to fix to help patients out, but it is, if you are not a candidate for a keyhole, then you should not have a keyhole. And that is a true statement. So those are just kind of things to keep in mind when you're kind of looking at risk versus benefit or advantages and disadvantages. If you are, I'm sure went through the process of considering, whether you wanted keyhole versus double incision. And so now, moving on to kind of the last piece of this, we also need to talk about the complications or the risks that are associated with the subcutaneous nipple and skin sparing mastectomies or keyhole top surgery. And these risks are also in addition to, of course, just general risks that you have from any type of surgery and receiving general anesthesia. So in addition to those, generalities, the risks associated with keyhole more specifically are as follows. The first one to talk about is bleeding. Remember, you're going to have drains in place. They can clot off really easily, though, if you have a brisk bleed. But you also, if you're oozing, most patients are going to ooze, and bleed a little bit after surgery. That's all very normal. So make sure that you are caring for your drains and stripping them appropriately so that they don't clot off. And then most bleeding is just going to, come out as some, bloody output into your drain. Not a big deal, or cause some bruising maybe across the chest. Again, not a big deal. That's all very normal, but I mean bleeding that requires us to go back to the operating room and fix, okay? Surgical bleeding. Surgical bleeding after a keyhole is, I would say, a little bit more common than with double incision top surgery, but still not common overall. Definitely less than 5%. I have not had to return to the OR for bleeding with the keyhole surgery, but it certainly can happen. And if that were to be the case, if you had surgical bleeding after a keyhole, then your suddenly one side would be very different than the other, to where you could barely look at the binder, and one side of your chest would have a blueberry sitting on it that was very tense, exquisitely tender, and looks blackish blue, and very, very different than the converse side, which is, healing normally. And if that were to happen, it almost always happens the same night of surgery. So you go home, from the recovery room after surgery or to your Airbnb or hotel, and then, several hours later in the evening or whatever, you notice this is happening, right? Which is why we always, request that you stay in town after surgery, because that would require us to go back to the operating room that night. We would reopen through the same incision, clean everything out, take all the clot out, all the excess blood out, wash it out, make sure nothing's actively bleeding. There almost always is not active bleeding. It's usually oozing from a vein. But if that were to happen, that's what we would do, and then close everything back up so that you can have a good cosmetic result. So ultimately, long-term doesn't really change your result, but obviously not fun or ideal for you to have to go back to the operating room in the same day, for you or for me, for that matter. But again, not common, but can happen. A little bit more common than in double incision, and if it does happen, that's how we would manage it. Seroma. Seroma is a collection of fluid in the surgical site under the skin. Seroma is a collection of serous fluid. Serous fluid is a very clear, yellow-tinged fluid that your body produces anywhere that you operate on somebody or make an incision. The body likes to heal or likes to fill empty spaces with fluid. And so as it fills an empty space with serous fluid, if it accumulates too much, it can form what's called a seroma. So as that builds up, that can become problematic and require drainage. However, we have to use drains for the keyhole operation, which helps some with the seroma fluid accumulation. And then we also, again, use a binder to give you compression, which also helps with that fluid accumulation. So I haven't had to drain seroma fluid from a keyhole patient of mine before, so it's definitely not common, but it can happen, and if it did, that's how it would be addressed. We can poke it with a needle here in the office, drain it out, knowing that over time it may reaccumulate and require multiple aspirations or drainages, and also knowing that you're also then buying the risk of introducing infection into the seroma fluid with the needle that you're decompressing everything with. And so because of that, we typically will try to not touch it because your body eventually will resorb all that fluid back and not cause any problems. But if it's persisting and persisting and persisting, then sometimes our hand is forced and we go ahead and drain it for you, maybe one time, maybe multiple times, in order to let everything heal properly and give you a good cosmetic result. So again, not common, but can happen. Infection, a couple types of infection. One is cellulitis. Cellulitis is an infection of the skin, an infection of the skin at the surgical site. It's going to be seen as a spreading redness when you touch it. It may be very tender when you touch it and may feel hot, similar to like a sunburn, and it may also be associated with a fever or other systemic or global symptoms. That is an infection of the skin. It needs to be treated with antibiotics. If it's mild, sometimes we can treat it with antibiotics at home via pills. If it's more severe or it's not resolving, then sometimes it requires a couple nights stay in the hospital to give you IV antibiotics, meaning antibiotics through your vein to help get control of the infection and prevent any further complications. A second type of infection you can get is an abscess. An abscess is a collection of pus at the surgical site under the skin. This has to be treated by two things: antibiotics, but also drainage. So we go back to the operating room, we open it up, we drain the pus, and clean everything out, and to make sure everything is going to heal appropriately. The chest is very vascular. It usually heals fairly well. It's pretty hard to get infected. In fact, I have yet to see an infection on any top surgery, double incision or keyhole. However, it's obviously a possibility, especially if you're jumping in a lake after surgery. But if it occurred, then that's how it would be treated. Wound healing complications, not common in this operation. We don't have the big incisions like we do with the double incision anyways. They're very small, periareolar incisions, not a lot of tension on them. So wound healing complications, again, very rare. I haven't really seen any issues. If they were to occur, it would be a separation of the incision, the skin edges, and would have to kind of heal in from the ground up over time and skin grow over it. Probably wouldn't change the cosmetic result too much. However, would take a little bit longer to heal in than had the incision stayed together. Scarring. There's no such thing as scarless surgery. As I mentioned, keyhole is as close as you can get pretty much for top surgery. But scarring that is unaesthetic or asymmetric can occur. This can be in the form of like a hypertrophic scar, which means it's raised, or it can be like a keloid that's both raised and outside the borders of the incision, so it gets wider. If anything like that were to occur with the small little scars that you have in a keyhole operation, then we would treat that with like silicone gels and things like that for scar care and treatment, or we could use injections of steroids like Kenalog to help, and then worst case scenario, a scar revision, either in the office or in the operating room, depending on what the operative plan was, to help revise that scar and give you a more symmetric or more aesthetic result, depending on what the problem was. Contour irregularities can happen. This means, maybe one area kind of scars down or the scar contracts down to your chest wall more than another area, giving you either peaks or valleys, basically, divots or bumps. Most of those contour irregularities work themselves out by 9 months to a year out from surgery, and everything is maturing. However, if that is not the case and you have some persistent contour deformities or contour irregularities on your chest, then that would require also revision in the OR. Typically, we're going to do that by either liposuction or fat grafting, kind of depending on what defect we're trying to fix or to help. Nipple sensation. I don't know how important nipple sensation is to you, but unlike double incision top surgery, we're not taking the nipples off the body and severing all the nerves and putting them back on in a new spot. However, we are making an incision around the underside of the nipple areolar complex, which severs some of the nerves, and then we're working underneath the nipple. We have to get under the nipple in order to get out all the breast tissue through that small incision, and some of the blood supply and nerve supply is coming from underneath as well. So we're getting rid of that, and we're getting rid of the underside as far as blood and nerve supply is concerned to the nipple. Still have all that intact above, right? So because of that, though, there is a little bit of a misconception with nipple sensation in keyhole surgery. For keyhole top surgery, most patients still have a decrease in nipple sensation postoperatively. It's not as prominent as with double incision. However, most of our patients do experience some decrease in their nipple sensation postoperatively, even after keyhole mastectomy, and that's why. And keep in mind too, as I mentioned before, it takes about 9 months to a year for your peripheral nerves to regenerate, since they only go a millimeter a day. So you may have little zappy, stingy, kind of lightning strike, like nerve pains intermittently that go on as the nerves are starting to kind of wake back up and regenerate. And then you may have little numb areas and things like that, or decreased nipple sensation postoperatively. And once you've kind of hit the year mark, that's usually about where you're going to be, moving forward. So if you kind of wait and see where you're at that point, that's a pretty good gauge of what your sensation and stuff is going to be like there moving forward. And then the last thing, nipple or skin necrosis. This means basically the nipple and areolar complex dying off, or the skin flap dying off. This is a theoretical risk. It has never happened to me before. I've never seen it before after keyhole top surgery. I have seen this happen with other people's patients during other procedures such as breast reductions and things like that, where the way that nipple and areola is handled is somewhat congruent or somewhat similar. In theory, this shouldn't happen because you should have nice thick flaps so the skin doesn't die. You should leave enough tissue underneath the nipple to where it has a good blood supply, and then you're only partially taking the nerves and blood supply away from it with the technique or nature of the operation. So again, I have yet to ever see this happen with this operation, so exceedingly rare. However, it's a theoretical risk that's out there, so you should definitely, of course, know about it. Although it's certainly never happened to me before, and is very, very, very rare. Lastly, just remember and keep in mind, I know we talked about this a little bit at the beginning, but this is not a cancer operation. If you have a significant family history or personal history of breast cancer or concerns, you need to talk with your surgeon and make sure you do some preoperative screening. Also, postoperatively, it does not cure or get rid of the risk completely of developing a cancer. It is risk reducing because we're removing most of the tissue. But in any mastectomy, whether you're talking about for a cancer operation or for this, 100% of the breast tissue, it's impossible to remove 100% of all breast tissue. And in these operations, double incision and keyhole specifically, we tend to leave a little bit more behind to have a nice fuller contour to look like a nice, kind of flat chest without any concave areas and things like that, to make sure the flaps are nice and healthy to survive. And so because of that, cancer is not completely off the table, even though the risk is greatly reduced. So regardless, if you notice anything in the future moving forward, you should definitely see your a physician, your primary care physician, or whoever it is that gynecologist, or whoever it is that or not gynecologist, but your primary care physician or a surgeon or whoever it is that you need to see to have a workup that may involve some imaging like ultrasound, biopsy, things like that. So just kind of keep that in the back of your mind. Definitely risk reducing, but not a cancer operation. So make sure if you have any concerns specifically related to that you discuss that with your surgeon as well. So overall, the keyhole, top surgery or subcutaneous nipple and skin sparing mastectomies is really, a well-tolerated operation. Most patients have very minimal recovery and have good results, but it's important that you kind of understand the process and understand the risks that are on the table when you talk about this particular operation. And if you have any questions or concerns moving forward, just be sure and ask your surgeon. Okay, thanks.